The broadcast is now starting. All attendees are in listen-only mode.
So, hello everybody. It's my great pleasure to welcome you to our webinar series. My name is Minerva Becker, and it is my great pleasure to introduce to you our distinguished speaker of today's webinar. It's Dr. Heidi Beate Eggesbø from Norway. And it's needless for me to introduce her. She's a well-known radiologist with a special focus interest in imaging and pathology of the paranasal sinuses. And she also has quite a large field of interest in other parts of radiology, general radiology, prostate imaging, cancer imaging. She is currently the head of research at the Division of Radiology and Nuclear Medicine at the University Hospital in Oslo, and she is a member of the board of the European Society of Head and Neck Radiology at the moment. So, my great pleasure to welcome all of you, and I will now give the presentation over to Heidi. Thank you, Heidi.
Thank you very much, Minerva, for this nice introduction, and thank you for all out there in Europe and out of Europe that are visiting this presentation. So let's start. The learning objectives you already have got. This will be about the sinonasal anatomy and the key anatomic structures that might predispose to inflammatory disease. I will review the most common inflammatory patterns. I will show you some pitfalls and also how to perform the radiology report. Imaging technique, it should always be CT. CT is a workhorse. It's the gold standard in paranasal sinus imaging. It shows the bony details. It shows the extent of opacification, and the surgeons use CT as a bony map during a surgery. MRI should be complementary to CT in differentiation of soft tissue masses, and usually I think that the patient should go from CT to the ENT surgeon, and then one should discuss if MRI is needed. Plain film is something we don't do anything more. We could see the sinus size, air fluid levels, septum deviation, but it's old-fashioned, so it has been replaced by CT. And remember that CT is always the first choice. If you do MRI as the first choice, the ENT surgeon will always ask for a CT. So what is clinically relevant in a radiology report? I always start with development. If it's normal, I just say normal development of the paranasal sinuses. If it's hypoplasia or aplasia, I mention that. And I also mention if there is a status after functional endoscopic sinus surgery. And then I go to the pneumatization variants, but only if it's relevant, because if there is no sinus opacification, I do not list all the pneumatization variants that I see, because the sinuses is like a fingerprint. No one is exactly the same. The maxillary sinus development starts as outpouching of the nasal cavity, and the first image you see, this is Down syndrome. They have hypoplasia, very grave, of the maxillary sinuses, which explain the facial expression. Then you have patient with cystic fibrosis. They have small sinuses. If you see that the bottom of the maxillary sinuses is above the hard palate, then I always report the sinuses as hypoplastic. Another feature with hypoplastic maxillary sinuses is the oval-formed orbit and also the low ethmoid roof. And sometimes you can see the sinuses very well developed, and this is also normal. And usually in persons with no mucosal sinus disease, they usually have larger sinuses and more pneumatization variants. Why should we bother about maxillary sinus hypoplasia? Well, the surgeons do, because the uncinate process is an important landmark during surgery. And you can see it here. And in this case, when it's hypoplasia, the uncinate process is laterally dislocated, and it's very easy to go straight into the orbit during surgery. On the other side, do you think that the patient had gone through surgery? Look carefully, because actually here you see the uncinate process just below the orbit, and this is actually referred to as a retracted posterior fontanelle. The surgeons usually do not do anything with this case. It is usually normal. You can also use soft tissue algorithm as in this case, and then you see that there is actually no high attenuation of the content. It means it's mucosal lining and just mucus. So just look for the uncinate process below the orbit. Then if you have a long-standing infection, a negative pressure might develop due to the obstructed sinus, and with time the sinus walls collapses, and the patient may present with enophthalmos. In this case, you also have this oval-formed orbit. So let's go to something quite difficult, the osteometal complex. It's quite many anatomical structures. It refers to the final common drainage pathways for the maxillary, anterior ethmoid, and frontal sinuses. The anatomic components of this complex is, first you have the maxillary sinus ostium, then you have the ethmoid infundibulum, you have the uncinate process, the semilunar hiatus, which is a two-dimensional opening from the maxillary sinus content. Then you have the ethmoid bulla, which is the most constant and largest of the ethmoid cells. You have the frontal recess, and finally you have the middle meatus. So all these components are referred to as the osteometal complex. Functional endoscopic sinus surgery. In this case, the uncinate process is a key area, as well as the OMC. And what the surgeons do, they remove the uncinate process, and this is referred to as uncinectomy. If they do a larger opening, they also call it media antrostomy. And antrum is the same word, another word for the maxillary sinus. Previously, they also did inferior antrostomy, but in this case, you only will have recycling of the mucus due to the mucociliary drainage, which always is out through the ethmoid infundibulum. Mediantrostomy is always performed prior to ethmoidectomy. And I also always report this, that this is status after mediantrostomy and ethmoidectomy if it has been performed. So let's go to the ethmoid sinuses. They are fluid-filled at birth. The first sinuses to develop already during pregnancy. And during the first year, they get air-filled. And adult site, it might be maybe as many as 18 cells on each side. And again, we have the ethmoid bulla. The posterior part of the ethmoid bulla is the border between the anterior and the posterior ethmoid sinus, and it's approximately at the level of the posterior orbit. On coronal image, you find the ethmoid bulla very close to the ethmoid infundibulum, and sometimes it may cause obstruction of the maxillary sinus. The Ethmoid sinuses has close relation to the ethmoid roof that consists of the ethmoid fovea and the olfactory fossa. And what the surgeons care about in this case, it actually not how deep the olfactory fossa is or the ethmoid roof, but they care about if it's asymmetry, because if they go into this side first, they expect it to be the same on the other side. So this should be included in the report if it's asymmetry of the ethmoid roof. Next, they also want us to report on ethmoid artery, because if they damage the ethmoid artery, it will sometimes just slip into the orbit and cause profuse bleeding behind the orbit. So they have to be really carefully not to damage this artery. And it looks sometimes like there is no bony bone around the ethmoid artery, but actually there usually is. So this is how it looks for the surgeon, but when you take off the mucosa, you see that the ethmoid artery is inside the bone. We're going to some pneumatization variants from the ethmoid sinuses. The most common is the infraorbital cells. This is cells that the surgeon cannot see through endoscopy, and it also causes the uncinate process to be dislocated medially, and the ethmoid infundibulum is quite narrow. Concabulosa is very common and easily seen for the ENT surgeon, but it may cause obstruction of the middle meatus and also dislocate the uncinate process laterally. And then we have the agenesis cells. This is the most anterior ethmoid cells. The frontal sinus is the last sinus to develop. Actually, it's the ethmoid sinuses that goes into the frontal bone. And first, when the ethmoid recess passes the superior orbital rim, is it defined as a frontal sinus. And this usually occurs at the age of 6 years. We have something called the frontal recess cells. These are cells pneumatized from the ethmoid cells. And Agar cells is one of them. It's the most anterior ethmoid cells, as I said, and it's a surgical landmark. And opening of this cell is the first step when they do surgery close to the frontal sinus. But you also have some cells above the agenesis cells. And this is classified into 4 types. It's type 1 if you have only 1 cell above the agar cells. 2 cells is type 2. Type 3 is an isolated cells up in the frontal sinus, and type 4 as well. And I think these 2 types are connected together now. And to see these anteriorly based cells, you have to have a sagittal view when you do the CT reconstruction. And these cells, they all have their connection anteriorly, and that's what the surgeon wants to know, compared to these cells. Sorry, I'm missing one image. The frontobular cell and the suprabular cells are cells that are connected to the posterior part of the frontal sinus. And they are in close relation to the agar cell. So this is a frontal recess, and these cells may obstruct the frontal sinus. Sphenoid sinus develops already from the first year, and by the age of 6, the pre-sphenoid is pneumatized, and then it continued to the basis sphenoid. And in patients with cystic fibrosis, it's pathognomonic. They only have pneumatization of the pre-sphenoid. If they have also pneumatization of the basis sphenoid, they have to find another diagnosis. Sphenoethmoid cells is posterior ethmoid cells that actually goes into the sphenoid bone if the sphenoid sinus develops slowly. And on the coronal images, you usually see 4 compartments. And what is important in this case is that the optic nerve actually lies inside the sphenoid cells. So when the surgeon had to go into the sphenoid sinuses, they usually have to go low and they have to go slow. Also, in case of anteroclinoid process pneumatization, we have the optic nerve inside the sphenoid sinus. Also, be aware of the close relation to the sphenoid sinus and the cavernous sinus. And as we see here, we have the carotid artery that sometimes also may bulge into the sphenoid sinuses and cause danger during surgery. So when you look at the sphenoid sinus on frontal images, always look for the maxillary nerve that goes through the foramen rotundum and the petrosal nerve that goes through the Vidian canal. So just test yourself and see if you can see these 2 canals. And I will show it. So exactly what you thought, I guess. So now we have gone through development and the most common pneumatization variants. I will proceed now to ossification. And what is important is where is ossification? It is small, moderate, advanced. What is normal? When is it going to be pathology? If you see ossification, is it acute or chronic? Is it rhinosinusitis? Do the sinusitis follow a pattern that the ENT surgeon wants to know? And always look for fungal sinusitis. It's much more common than reported. Always look for neoplasm in case of unilateral ossification. And which I have not mentioned here, always look for odontogenic sinusitis. So let's start with normal, because ethmoid sinuses, the mucosal lining is visible due to the nasal cycle, and in the maxillary, mucosal lining till 4 millimeter is should be reported as normal. But in the frontal and sphenoid sinuses, the mucosal lining should not be visible. The mucociliary drainage route for each sinus is unique. And for the maxillary sinuses, it goes through the ethmoid infundibulum. And from the frontal sinus through the frontal recess, as I mentioned for you. So what happens when this drainage route is obstructed? The sinuses produce 1 to 2 liters of mucus every day. And in case of obstruction, the sinuses fills up, and if long-standing, it will cause a chronic infection. And I've also listed some causes of obstruction. It can just be mucosal thickening, and yeah. But yeah. So this is a teaser I sent you. I do not know if how many saw it, but this is unilateral ossification. Is it rhinosinusitis? Is it chronic? What is the cause actually? And also you see here, medially, there is some less bone. And this is often normal when there is something protruding into the nasal cavity. This is just demineralization of bone. This is not destruction. And as we see, there is no sclerotic thickening. But we have something in the sinuses. close to the ethmoid infundibulum. So actually this is, I call it odontogenic rhinosinusitis. It's actually a part of a tooth that had loosened and gone into the maxillary sinuses, and now it's trapped into the ethmoid infundibulum and causing sinusitis. And on MRI we see it as single void close to the ethmoid infundibulum, and also see how close the ethmoid infundibulum is to the lacrimal duct. Five inflammatory patterns have been described by Hansberger. The first, if you have obstruction at the ethmoid infundibulum, you call it infundibular pattern. If you have obstruction at the middle meatus, you will have ossification of the ipsilateral maxillary, ethmoid, and frontal sinus, and we call it OMC pattern. Then we have from the posterior obstruction of the sphenoethmoid recess, and all these three patterns actually are obstruction of the mucociliary drainage routes. While the fourth pattern is polyposis, and you recognize the remodeling of the ethmoid sinuses and also the widening of the ethmoid infundibulum. And all the rest that does not fit into the first four patterns we call sporadic, and it could be small polyps, small mucosal lining thickenings, retention cysts. So this was first described by Hansberger in 1991, and his paper, The Major Obstructive Inflammatory Patterns of the Sinonasal Region Seen on Screening Sinus Computed Tomography, is worth reading. I will now show you three common pitfalls in paranasal sinus imaging. It's not about interpreting, but it's how to take the images. So one main pitfall is cutting the alveolar ridge. Usually the technicians did that in order not to get the artifacts from dental fillings into the sinuses. But now you do not know what is behind here. Could it be an odontogenic infection that causes this maxillary sinusitis? But if you don't want to report on it, of course, you can just keep on doing imaging like this. I think there is something with a tooth here. And the next is, if you do coronal imaging, you will have a lot of artifacts into the sinuses. So this patient had to come back and do a new CT examination with axial scanning volume. And this time it looks quite nice. Then pitfall 2 is to use too thick slices on bone imaging. One should use slice thickness no more than 1 millimeter. And here you see both, you have artifacts going into the sinuses, and it's very easy to miss this odontogenic infection that caused chronic rhinosinusitis. This is a paper from 2017, and it says that when maxillary sinuses does not heal. So in this paper, they found of 300 sinus examination, they found that 40% of unilateral maxillary sinusitis was due to odontogenic infection. So it's very important, always include the teeth in the scanning volume and always look for odontogenic infection. As in this patient, it's bilateral maxillary sinusitis. The sinus is bulging into the nasal lateral to the nasal into the nasal cavity, and here you see that this dental infection on both sides, and this was not reported on, and this had been long-standing because it's very sclerotic bone. So always, when you see maxillary sinusitis, always look at the teeth very carefully. And sometimes also the patients think that he has an infection in the maxillary sinus, but actually he has an infection around a tooth that may cause pain like maxillary sinusitis. So this should be reported on and the patient sent to the dentist, not to the ENT surgeon. And also look carefully if you see retention cyst. It's very common in 10 to 30% of all CT examinations. But if you see a sclerotic border, it's no longer a simple retention cyst, it's a radicular cyst, or it can be an odontogenic tumor. So this you should report on. The third pitfall is soft tissue algorithm is missing. In this case, all ossifications is gray, 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 and you hardly can interpret what's inside. If you see this, always ask the technician to reconstruct with soft tissue algorithm, and you get a lot more information. So in this case, you see that you have high attenuation centrally in the maxillary sinuses. So this is equal to a piocell. This was a patient with cystic fibrosis, sclerotic bone, chronic infection. We see demineralization of the lateral nasal wall. This is not destruction. And if you look carefully, you also see that something is coming out from the maxillary sinuses. So this is an antroconal polyp in addition to bilateral piocell. On the next case, you see this calcification. If you look carefully, you always also see it here, but it's very easily to miss. So when you see this, you know that this is fungal sinusitis. This is a fungal ball. And on this, you have high attenuation in several sinuses, and that is quite typical for allergic fungal sinusitis. So you get a lot of information if you just also reconstruct in soft tissue algorithm. In these cases, you don't need an MRI. You can just send the patient to the ENT surgeon. And this is, again, a calcification. And what do you see here? Outside the sinuses. You see something in the fat plane outside the sinuses, and this is equal to fungal sinusitis. And when you see something outside, you know this is invasive fungal sinusitis. And remember that bone algorithm should be no more than 1 millimeter, but if you have soft tissue algorithm, it should be 2.5 approximately, not 1 millimeter. So what I actually showed you on the two last slides, I showed you the classification of fungal sinusitis. So it's quite easy. Either it's non-invasive, then you have a fungal ball, or you have allergic fungal sinusitis. And if you see something outside the sinuses, it's invasive, and you have acute and or chronic form. And you know the difference because in acute form, the patient is very ill. And in this case, you should always look pre-antral, retroantral, and also look for an eschar in the nasal septum. And even if you have a sclerotic thick bone, the fungal goes through the wall, through the arteries, and then goes on the behind the sinuses. So always look outside on soft tissue algorithm. Unilateral ossification, is it rhinosinusitis or is it neoplasm? Always rule out neoplasm, take an MRI or send to the ET surgeon first. But there are some general rules. Benign tumors, they cause thickening or remodeling of adjacent bone, as in this case was a schwannoma. And in this case, you see that the bone is destroyed, and this was an adenocarcinoma. But unfortunately, the radiologist reported this as an ethmoid sinusitis. And this also of course, delay the diagnosis of paranasal sinus malignancy, and also explain why most paranasal malignancies are classified as T3 or T4 when they come to the ENT surgeon, because the patients, they postpone, call it, think they have a cold, maybe the doctor as well, and then if you finally have a blind radiologist, this will postpone the diagnosis for many months. This is difficult. All of them have unilateral opacification. So what do you actually see? You have to look carefully. You have to look carefully through all planes, soft tissue, algorithm, which you do not have here. But if you see carefully, you will find this calcification. So this is a fungus ball. This has odontogenic infection, I showed you previously. But the rest, you actually cannot. It looks all the same. So you cannot actually differentiate an antroconal polyp from an inverted papilloma, from a malignant tumor like esthesioneuroblastoma or mucosal malignant melanoma. So unilateral opacification, be aware. And simple polyps may turn out to be malignant. So that's why I usually like to use retention cyst about the small cyst in the maxillary sinuses, because when I use polyps, I think it's more malignant. So polyps in the nasal cavity should always go to the ENT surgeon. In this case, we have esthesioneuroblastoma, actinic cell carcinoma, malignant melanoma, and squamous cell carcinoma. And you can actually not from the images tell that this is really malignant. So to finalize, what should be in a radiologic report, start with development. If it's normal, just say it's normal development. Don't report all pneumatization variant if it's not relevant, but look for them and see if they are in connection with opacification or sinusitis. And opacification, if it's small mucosal thickening, we can say it's just normal. Don't over-report nasal cycles, this nasal cycle, and then with a big concha media, it's normal. But always look for the acute or chronic. Chronic is always sclerotic sinus walls. See if you can, it fits into one of the 5 inflammatory patterns. And always look for fungal sinusitis. Look also outside the sinus, and always consider a neoplasm when it's unilateral. And what you should take home to your technicians is these 3 common pitfalls that you should avoid. Don't cut the alveolar ridge. Use small thickness for bone algorithm, and always remember to use soft tissue algorithm when there is something inside the sinus. And to finalize, patient preparation is just to blow the nose. Thank you for your attention.
Thank you very much, Dr. Eggesbø, for this nice presentation. I'm now happy to moderate any arising questions. So if you have a question, please use the raise your hand function and you can talk live to Dr. Eggesbø, or you can also type your question into the questions field. So let's wait a few seconds for any questions to come in. So we have one question from Anja Bernards. I'm going to unmute you so you can so you can talk live. 1 second. Dr. Bernards?
It's an error. I'm sorry. It's just I was
Okay.
trying out the program. I'm sorry.
Okay, so we have a question from Dr. Hiremat. The question is there any specific level on coronal images to measure the depth of olfactory fossa in Keros classification?
No, I think, yeah, thank you for the question. I think you should just use the coronal image with the deepest olfactory fossa. And it's usually very close to the level of the osteomeatal complex.
Okay, and we have another question. Is there a difference between low-dose sinus CT or full-dose CT in assessing bone and soft tissue? Which one do you use routinely?
For screening, you can go as low as CT machine can do. It can be as low as 16 kVA. But if you have a tumor, you should be no less than 50.
Okay, we have a question from Dr. Spencer. I'm going to unmute you so you can talk live now.
Hi, lovely presentation, thank you. You said that on the last slide that you only need to blur the nose. Do you ever scan patients on maximum medical therapy?
I was a little bit noise. Can you please repeat?
Your last slide suggested the patient should only blur their nose before the scan.
Yeah.
And my question is whether the patient should be on maximum medical therapy like steroid, aerosols and so on before you scan.
No, some recommend it, but we do not do it. And I think if they just remember to blow their nose, that will be fine, because sometimes there's so much mucus in the nasal cavity. And if you have a patient with anchivasculitis, Wegener's or something, that is sometimes they do have fillings in the nasal cavity. So it's important to remove what is loose. It can come out.
Thank you.
Okay, we have another question from Dr. Sunita Gopalan. I'm going to unmute you. Dr. Gopalan? Are you there? Then we have a question from Dr. O'Hare. Could you please clarify the difference between retracted posterior fontanelle, silent sinus, and hypoplastic sinus?
Okay, we start with hypoplastic sinus. It's the bottom of the maxillary sinus is then above the hard palate, and the sinus is round, not retracted as in silent sinusitis. In silent sinusitis, you have all borders of the maxillary sinus retracted, but in retracted posterior fontanelle, it is only the lateral nasal sinus wall that are retracted into the maxillary sinus. So retracted posterior fontanelle usually is not a rhinosinusitis. The sinus is just filled with mucosal lining and mucus, but in silent sinusitis, you usually have a chronic bacterial infection or a low pressure. So you need to open the maxillary sinus with an antrostomy. Was that clear?
Yes, thank you very much. And another question From Dr. Markus Kopp. Do you use a structured report in your daily routine?
I usually always follow this report but my colleagues do not. Usually many just start and report on all the opacification, if it's only a small retention cyst, mucosal thickening or so on, but I usually report on what the ENT surgeon wanted to do or to know and what's related to the procedure they are going to plan. But of course, to have a multidisciplinary team and report together with ENT surgeons is also important, because you learn a lot and they are often interested in much more anatomy than we actually put in a radiology report.
Thank you very much. And if you agree, I would take one last question. A question from Dr. Rick Wiggins. Do you use MRI for fungus invasive evaluation?
Sometimes we do that, but I think that CT is enough. And if you do the soft tissue reconstruction, I think sometimes it is equal to MRI to look outside, but that depends on what the surgeons want to do. I think the most important is that we actually report on fungal disease, because it's often not reported on, just we call it rhinosinusitis.
Thank you very much. So should we take another question? We have many more questions, actually. So let's just take one more from Dr. Laura Neemane. What do you think of using CBCT for sinus imaging?
That's a good question. It's very nice for the bone algorithm, but what you cannot do with the cone beam CT is to reconstruct with the soft tissue algorithm. So I think you lose a lot with the cone beam when it comes to the paranasal sinuses. And if you see a opacification at cone beam in the paranasal sinuses, you always have to do an MRI. And in Norway, we do not have capacity to do so much MRI. So I think it's better to do not use cone beam CT for the paranasal sinuses.
Thank you very much. So I think we will close the webinar. Thank you, Dr. Eggesbø, again for this very nice presentation.
And thank you for all listening.
And we hope to see you at the next webinar coming soon in February. You will find all the information on the ESHNR website, and registration will soon be online. Thank you very much and have a nice evening, everybody.